I'm happy to be here and thank you again for the invitation. So my topic for today will be malformations of cortical development, genes and their imaging correlates. I'd like to begin by acknowledging many of my colleagues and mentors over the current and past few years from CMC, SIG and GOSH. And also thank you for sharing some of the cases that I'll be showing on this presentation. So the brief outline of my talk is I'm going to start off by discussing normal cortical development, followed by describing normal cortical anatomy on MRI. And then we'll go into broad classification of malformations of cortical development. And then we look at genes and some imaging correlates. So the process of cortical development begins as early as the fourth week of gestation when the neural tube is closed. So that's when neurulation and neurogenesis occurs. And then a few weeks later, you can see neuronal migration occurs between early to late gestation periods. And a lot of these processes show a fair amount of overlap. So this is just important to keep in mind at this stage. So if we are going back to the embryonic day 28, this is when the neural tube has closed and we have a rudimentary brain and spinal cord. Proliferation begins at this stage. So there are two zones. One is the dorsal telencephalon, and that's like an oblique cross-section of the cerebral hemisphere, and that's the ventricle there. That's the ventricular margin. So the bone morphogenetic progenitor induces the dorsal telencephalon, which is the ventricular zone, and sonic hedgehog induces the ventral telencephalon, which we can see over here. And this comprises of the lateral and medial ganglionic eminences. So the glutamatergic neurons, which form the majority, that is about 90% of the cortical neurons, they proliferate here in the ventricular zone. And they migrate in what is known as radial migration. And it is known as radial migration because it's at 90 degrees to the surface. At the ganglionic eminence is where the inhibitory neurons, that is GABAergic interneurons, proliferate. And if you see the migration pattern, it is slightly different. This is parallel to the surface of the ventricle. So this is known as tangential migration. Although initially they do have tangential migration to this level, followed by radial migration, and in order to reach the layers of the cortex and form the 6-layered normal cortex. So let's take a slightly closer look at the ventricular zone. So that's the ependymal surface, and that's the peel limiting membrane there. So you have proliferation that takes place not only in the ventricular zone, but also in the outer subventricular zone. And this is especially important in humans and as an evolutionary something of that is quite specific to humans. Migration, as I mentioned before, starts in the early week, first few weeks of gestation and continues up to second trimester, and then organization occurs. That goes on well into postnatal life. And this is again just a graph showing the different processes and the various overlaps. So one important point, again, the outer radial glial cell, this is important from an evolutionary perspective in humans because this provides a lot more space. The outer subventricular zone provides a lot more space for the proliferation of neurons. Okay, so looking at early proliferation. So at this point, this begins in the 4th week of gestation age. So we have these precursor cells that proliferate, and then they form the apical radial glial cell. So initially, these radial glial cells divide symmetrically to form, two daughter radial glial cells, and then soon they start dividing asymmetrically to form a neuron as well as a radial glial cell, and then this process repeats itself until the subventricular zone is also populated with progenitor cells, uh, during which massive proliferation continues to occur. And you can see here that the um, migration is occurring via the radial pattern. And many genes are implicated. This is an oversimplification, what I'm showing here, but essentially these depend on mTOR pathway signaling. And then certain genes such as ASPM and WDR62 are involved in centriole biogenesis and mitotic spindle orientation, which are required for proliferation. Migration also, there's actually two different ways. So initially it's a nucleokinesis. Essentially that means it's almost like um, the neuron jumps from one segment to the other, and these are governed by LIS1 and DCX. And then later on, radial migration across the scaffold occurs again via various genes, filamin A being one of the important ones. And then the marginal zone, so the earliest cells that populate the marginal zone are the Cajal-Retzius cells. These play a very important role because they induce these migrating neurons to detach from the radial glia. And that results in an inside-out pattern, which basically means that the youngest cells are more superficial than the older cells. The marginal zone eventually becomes the glial emittance, and this is formed by the astrocytic footplates. And this is the glial emittance is extremely important because it serves as a barrier between the cerebral spinal fluid space and the CNS parenchyma. And in the context of MCDs, it limits the overmigration of neurons. So this is just a schematic showing the glial emittance. And in a normal case, the neurons are going to be below the glial emittance. So what happens post-migration? The cortex is arranged in different layers. So we can see the 6-layered cortex, which is seen in the majority of the human brain. And then, there's formation of axons, dendritogenesis, and synaptogenesis. So over time, the volume of the brain itself grows. And then we have primary, secondary, and tertiary sulcation, of which primary and secondary sulcation are quite predictable and symmetric, whereas tertiary sulci vary considerably. And as I said before, 90% of the cortical surface of the human brain comprises of the neocortex that is made of 6 layers, whereas the paleo and archicortex comprise of either 3 or 4 layers. So this is just an extremely magnified view of the motor strip, and this is a 3 Tesla MRI. So you can see we can't actually resolve the layers of the cortex. Maybe you can see 2 layers there, but essentially, in clinical MRI practice, we can't resolve the layers at present. There have been some very encouraging results from ultra high resolution MRIs at 9.4T, but this is still in ex vivo, and you can actually see the laminated pattern a lot better on these experimental studies. So what's normal cortical and sulcal anatomy? So the thickness is variable between 1 to 4 millimeters. It is thicker at the crown of the gyri and thinner at the base, that is at the level of the sulcus, bottom of sulcus. And primary and secondary sulci, they are formed usually by the 3rd trimester of age, and they are constant and symmetric in location. So here we can see the parieto occipital sulcus, again symmetric on both sides, and the calcarine sulci. So this is the primary sulcus, this is secondary sulcus, and then tertiary sulcus are little branches that arise from that, and these are extremely variable. And normally the sulcal width is, the sulcal depth is much greater than the sulcal width. And this is an important concept when we are looking at some cases of simplified chiral pattern. Okay, so after that brief introduction into cortical development, let's look into the classification of malformations of cortical development. So there are three broad categories, and again, there can be a lot of overlap because we have seen that many of these processes undergo simultaneously. But essentially, for practical purposes, we can divide them into disorders of proliferation, migration, and post-migrational development. So let's begin by looking at malformations due to abnormal proliferation or apoptosis. So starting off with if there is decreased proliferation and or increased apoptosis. So that is a small brain. So microcephaly is defined as a reduction in the occipital frontal circumference below 2 standard deviations compared with age and gender matched controls. Primary microcephaly is when it has occurred at birth, whereas secondary is a disruption post neurogenesis and postnatally. And you can see there's many causes for primary microcephaly, that is, if the cell size, the progenitor cell size, and we saw the ventricular zone and subventricular zone, etc., how important they are for proliferation. So if the progenitor cell size itself is small, then the resulting brain is also small. Other important factors are decreased number of pull cycles or increased apoptotic events that can occur due to, again, many genetic conditions. Secondary is disruption. So again, hypoxia, infection, toxic or deprivational causes. And then again, there are neurodegenerative conditions that can be genetically driven that can cause secondary neuronal loss and microcephaly. So in both primary and secondary, there can be acquired and genetic causes. So again, genetics, as we all know, is ever expanding, and it is difficult to keep up. So this was in 2020 when OMIM listed 25 genes related to primary microcephaly, and then when I searched a few days back, this currently has 30 entries. So just going back to what happens during proliferation, we saw that it depends on mTOR signaling pathway and then certain other molecules, and that we can see in more detail in this really nice paper, recent paper by in Frontiers of Neurology. So we can see based on this that a lot of genes that are involved in microcephaly are responsible for centriole biogenesis and mitotic spindle orientation. And then some genes are involved for many of these processes. So take a close look at ASPM gene, for example, which is involved in Wnt signaling, centriole biogenesis, and mitotic spindle orientation. And the other important one is WDR62. These two are important because the overall diagnostic yield of whole genome sequencing is still not, is about 50%. And majority of those are going to be either the ASPM gene or the WDR62 gene. So it is worth concentrating in that area. So let's start off by looking at some cases. This is a 2-year-old female with developmental delay. So what are the findings that we see? There is microcephaly, and that we know from the clinical details, the head circumference. From a radiological point of view, we can see there is relative small size of the head relative to the face. What else do we see? There is a simplified gyral pattern. And this can be a little tricky to see, especially in these cases, because they are so symmetric. But I think the idea is to always compare with normal aged children, and that gives you a better idea of what it is. But in this case, the sulci are quite shallow, and it has a very simplification kind of pattern. So what's the radiological impression? So I think on imaging, all we can say is there is microcephaly and simplified gyral pattern. It is very non-specific, and the history is important. Of course, a lot of the acquired causes need to be excluded. And then, once there is a strong indication that this might be a neurogenetic cause, the respective panel can be run. And in this case, it was an ASPM pathogenic variant, which is a cause of primary microcephaly type 5. So ASPM is the most common autosomal recessive primary microcephaly. And as we saw, it occurs due to defective Wnt signaling, centriole biogenesis, and spindle orientation. And the most common phenotype of this is a microcephaly with simplified gyral pattern. Case 2, here again, we have sagittal T1, axial T2, and saddle T1 weighted images. So we see again microcephaly, the corpus callosum is quite dysmorphic. Again, the folding pattern is very simplistic. And then there is a lot more going on here, which we can appreciate better on the sagittal T1 weighted images. So the cortex is very irregular, with a stippled appearance. So there is microcephaly, simplified gyral pattern, and polymicrogyria in this case. And in this particular instance, it was a WDR62 pathogenic variant, which is the second most common gene involved. Why is there polymicrogyria? Because WDR62 is involved not only in neuronal proliferation, but also in migration. So the different radiological phenotypes that can be seen are microcephaly, simplified gyral pattern, polymicrogyria, and also heterotopia because they're involved in migration. This is a companion case. This is also a WDR62 pathogenic variant, but note the phenotypic variability here. And this is an important concept that we need to keep in mind, that mutations in the same gene can cause different phenotypic appearances. So in this particular case, both axial T2 weighted images, we can see a simplified gyral pattern on the right, but on the left, there is polymicrogyria. Moving on to case 3, this is a 4-year-old male with developmental delay, drooling, and feeding difficulties. Axial T2, axial T1, T2, and sagittal T1 images. So what are the findings here? So we see this large, almost mass-like area of gray matter, and we say it's gray matter because it is iso-intense to cortex there. And this is in the perisylvian regions. And then we see that better on the T1 weighted images as, almost like a nodular as well as a linear type of gray matter signal intensity. The rest of the brain is also not normal. We see a simplified gyral pattern, and there is microcephaly. And the sagittal image just nicely shows the appearance of this heterotopia. So the radiological impression is that there is microcephaly, simplified gyral pattern with a very nodular and curvilinear kind of peculiar pattern of heterotopia. So this particular case is quite striking. And whenever we see this perisylvian heterotopia, we must think of SEP135 and SENPJ pathogenic variants. In this case, this was SEP135, and these are involved in centriole biogenesis. This is a companion case, another 13-day-old female with the same SEP135 pathogenic variant. So we can see again that nodular and almost, a sort of linear and nodular areas of heterotopia. Again, the distribution is quite typical in the perisylvian and temporal regions. This patient also had periventricular nodular heterotopia, as we can see, and this massive posterior fossa cyst that extends into the supra tentorial compartment. So again, it's a CEP135 pathogenic variant, slightly different phenotype, but the common factor being this perisylvian nodular polymicrogyria. So in the context of microcephaly plus this form of subcortical heterotopia, think of CEP135 and PJ genes, both of whom are involved in the central biogenesis. Case 4, this is slightly different pattern. This is a 1-year-old male with developmental delay. Again, this is a 1-year-old. So in addition to the simplified gyral pattern, if you notice, the white matter is quite bright on T2, slightly hyperintense on T1, but definitely not as much as expected for age. By 1 year of age, we should see an almost complete myelination pattern on the T1 weighted images. In addition to that, the corpus callosum looks a bit funny. It's almost a bit dysmorphic. There is some thinning anteriorly. Essentially, this is a soft marker for a neurogenetic etiology. And of course, there was microcephaly. So that's the radiological impression, microcephaly with delayed myelination. The clinical history was important in this case. This patient presented with the Rett-like syndrome and turned out to have a FOXG1 mutation. So FOXG1 is not one of the primary microcephalies. It's a congenital variant of Rett syndrome. And the important point here is that microcephaly may be secondary, that is due to degeneration. They can be both primary and secondary components here. It might start off as being small and progress at the same time. So they can be both components. So these are some of the important genetic causes of secondary, and that is postnatal microcephaly, where initially the brain size may be normal or near normal, and then there is degeneration over time. So FOXG1 and MECP2 are both related to Rett syndrome. CASC is this is a serine kinase, and this is also involved in a formation of the midbrain hindbrain structure. So you can see here a pontocerebellar hypoplasia phenotype along with microcephaly and simplified gyral pattern. TSN54 is the classic dragonfly appearance of the cerebellum. So pontocerebellar hypoplasia type 2 and type 5. And in this particular case, you can see there has been volume loss in the supratentorial compartment involving both gray and white matter over time, in addition to the pontocerebellar hypoplasia. So moving on now to disorders due to increased proliferation or, this should read decreased apoptosis, not increased apoptosis. So these are the brain overgrowth spectrum disorders. So as a simplification, brain overgrowth spectrum, essentially it means there's an increase of brain parenchymal volume. This can be focal or diffuse. It can be associated with either a normal cortex, abnormal sulcation, or they can be frank dysplasia. And we can see 3 examples here of cases of enlarged head circumference with megalencephaly. This is a normal cortex, and I put normal in brackets because on imaging it looks normal. There might be some things that we are just not able to resolve yet. In this patient, if you look, this is a relatively new term, dysgyria, that is the sulcal orientation and pattern is a bit different, but the overall cortical thickness is still maintained. So for lack of a better term, it does not fit into cortical dysplasia or polymicrogyria, but it also does not look completely normal. So this term dysgyria is used in these cases. This is a case of Soto's syndrome. And finally, they can be frank. There is a generalized overgrowth, but there is frank dysplasia here involving the posterior quadrant. So there are various the most important is the PIK3K AKT-mTOR pathway, and tuberous sclerosis is part of that. Other important pathways are the GATOR pathway, the RAS-MAPK pathway, of which NF1 is a part of, and of course the sonic hedgehog pathway. So the spectrum of brain overgrowth syndromes, and we saw this in the previous slide, this is just megalencephaly with normal appearing cortex. This is megalencephaly with dysgeuria, and we see that because of a number of shallow appearing sulci with a sort of funny orientation. We can see that especially here in the left frontal lobe there. You can also see generalized ventriculomegaly, but this is not due to white matter volume loss. This is ventriculomegaly just related to the overgrowth. Hemimegalencephaly, again, there is enlargement of the right cerebral hemisphere, including the right lateral ventricle. There is extensive cortical dysplasia. And we can also see T2 hypointensity of the white matter at various stages, which relate to accelerated myelination compared to the left side. Lobar hemimegalencephaly, again, it's when it does not involve the entire cerebral hemisphere, but involves two or more hemispheres, and again, extensive dysplasia. And these are usually complex malformations. They can have components of both cortical dysplasia, migrational abnormalities, polymicrogyria, etc. And frequently, the white matter is also abnormal. Tuberous sclerosis, you can see multiple cortical tubers and subependymal nodules. Again, it's an mTORopathy. And finally, focal cortical dysplasia. This is a classic type 2B focal cortical dysplasia with a transmantle sign. So all of these disorders are essentially, they occur because of abnormal overgrowth. And the reasons for these differences are many. One is the pathway involved. Secondly, are they somatic or mosaic mutations? And are there second hit mutations and things like that? So you can have a small area of focal cortical dysplasia. You can have a large area of hemispheric involvement, or just enlarged head size with or without dysgeuria. So this is the mTOR pathway, and these are some of the mutations that we saw. So P10, AKT, mTOR, of course, very important. Tuberous sclerosis, we know there's two types. And finally, the GATOR pathway comprises of DEPTC5 and PRL3 and 2. And of late, a lot of importance has been given to DEPTC5 mutations in focal cortical dysplasia. So let's look at case 5. This is a 14-year-old male with macrocephaly and skin changes, and the SAG image is just a good starting point to get an idea of the degree of macrocephaly. At this point, we can also see the corpus callosum is quite thick. Again, a common finding in many of these overgrowth syndromes. The posterior fossa looks a bit crowded, and that tells us that it's not overgrowth is not necessarily confined to the cerebral hemispheres, but can also involve the cerebellum. Axial T2 weighted image shows ventricular enlargement. Again, this is asymmetric. You see larger enlarged size ventricle on the right compared to the left. But other than that, maybe a bit of dysgeuria, but no other malformation. And this boy also had a capillary malformation. So the clinical diagnosis was quite straightforward. This was megalencephaly with capillary malformation, and this patient had a PIK3CA mosaic mutation, and we know that it's an mTORopathy, and it forms a part of the spectrum of overgrowth syndromes. This is a companion case, and again, the sagittal T1 image shows us the macrocephaly. There is again a thickened and dysplastic corpus callosum. The posterior fossa again looks a bit crowded, so there's a generalized overgrowth. But in addition to that, notice what's happening in the cortex of the right cerebral hemisphere. There is a stippled appearance, and essentially there is it's polymicrogyria on the right with some dysgeuria on the left. So again, similar to the other case of WTR62 that we saw, the findings can be asymmetric and the phenotypes can vary significantly. Another important concept to remember is that these various pathways do not function independent of each other, but are, there is a lot of crosstalk between them. So you can see the RAS-MAPK pathway, the PIK3CA pathway, and the SHH pathway here, interacting with each other. And the common end goal may be an increase in cell proliferation. So it's important to keep that in mind because, and all of these various pathways, you can see the final outcome can be that of overgrowth, and depending on what is involved, it can be either be a generalized cerebral overgrowth, or in this case of NF1, there was an isolated macrocerebellum. This is a case of focal cortical dysplasia involving the sulcus here in a patient with a DC5 mutation. So again, different gene mutations can cause similar imaging phenotypes, and that happens when we look at the pathway as a whole and not individual genes as such. Moving on to malformations of cortical development now due to abnormal migration. So starting off with arrested migration. So these can be because of any process that arrests migration from the ventricular zone up to the marginal zone. So we look at heterotopias and the lysine-Kefali spectrum here. What are heterotopias? As a simplification, you can just call them groups of neurons in an abnormal location. So again, looking at this diagram here, the neurons proliferate in the ventricular and subventricular zone and then migrate to reach the cortex. So if this process of migration is arrested at any point, you can have heterotopias, and depending on where it is arrested. So if it's arrested at this level, it's periventricular heterotopia. Some of them can have funny transmantle-like appearances. We saw examples where masses of heterotopic nodules were in the subcortical region. And then there's another subtype called laminar subcortical heterotopia, where it's a very thin layer of heterotopic gray matter along the subcortical white matter. Subcortical per se can be subdivided into band, nodular, curvilinear, and ribbon-like, and we saw examples of this. We will see an example of this coming. Subcortical band heterotopia is essentially part of the lysine-Kefali spectrum, so we'll discuss it along with that. So case 6, 11-year-old female, again important here, with headaches, otherwise normal, no seizures, no focal neurology. So axial T2 weighted, diffusion weighted, sagittal T1 weighted image. So the findings are, there is this obvious symmetric nodules along the lateral ventricles, and they are isointense to the cortex. So the B1000 of the diffusion weighted image is actually quite useful for picking these up, and you can, it kind of lights up on this because they are isointense to cortex, so they appear quite prominent. So it's useful when you're looking for PVNH to just as a screening also quickly look at the diffusion weighted images. This patient also has this large retrocerebellar cystic structure. There is some scalloping of the bone, so it's long-standing. And so radiological impression here is going to be symmetric, and then we describe the pattern of involvement. This was frontal and central predominant, and there's a retrocerebellar cyst. In this patient, in a female, she had a positive family history as well. This constellation of findings is very strongly suggestive of FLNA mutations, which is X-linked, and the imaging can many times suggest the diagnosis in females with a positive family history. So in these cases, targeted gene testing can be done instead of whole genome sequencing. Again, the most common pattern here is the frontocentral pattern, and frequently they have a retrocerebellar cyst or a megacyst magna. So periventricular nodular heterotopias, again, there can be a lot of phenotypic and genetic heterogeneity. So this paper, for instance, showed 105 PVNH associations, 45 involved multiple genes, 60 involved single genes. It can also be seen as an incidental finding. One study showed that 0.5% of the normal population had one or more PVNH. So when do we suspect a genetic cause for PVNH? If they are multiple, if they are bilateral, if there are other malformations, then you consider genetic etiologies. These two cases are courtesy of Dr. Nihal from Hyderabad. So case one, we can see, again, similar to the previous case, nodular heterotropia. They are not as large. They are somewhat smaller in size, but the distribution is similar. This patient also had dystonia, and we can see that the basal ganglia are small in size, especially the putamen, and there is some high T2 signal there. So in the presence of these two findings, that is striatal volume loss and signal change with dystonia, they're quite strongly suggestive of two pathogenic variants, which, like FLNA, have a role in vesicle trafficking. So consider this, in this constellation of symptoms, and if there is movement disorder and progressive microcephaly. The second case, again, the distribution of the nodular heterotopia is quite important. We see an infrasylvian or posterior predominant pattern in this case. So fairly extensive nodular heterotopia along the ventricular margins in the trigones and occipital regions. In addition to that, the cortex is diffusely abnormal here. We can see polymicrogyria cortex, as well as almost like a polygyria kind of appearance without frank polymicrogyria. There is also an enlargement of the right cerebral hemisphere. It's not from the same patient because I did not have an image, but this patient also had a similar finding that we can see here, that is syndactyly. So this constellation of features should alert us to the possibility of NED4L pathogenic variants. It is an mTORopathy, and if we see posterior predominant PVNH in addition to polymicrogyria and syndactyly, we should consider this. They frequently have cleft palate as well. And the other differentiating feature is that they typically have macrocephaly rather than microcephaly, what we saw in WDR62, and I guess that can be explained by the fact that it's an mTORopathy. So lysencephaly, at its simplest definition, means smooth head. It is a spectrum, so it includes agyria, pachygyria, and subcortical band heterotopia. As we can see in this example, so this is the most extreme form called agyria, where you have a figure of 8 appearance. You only have very rudimentary sylvian fissures, but no other sulci are formed. This is pachygyria, where there is some very shallow sulci that are formed, but also the very thickened cortex with smooth outer margins. And finally, this is subcortical band heterotopia, and we can see, appreciate that posteriorly, especially cortex. This is the subcortical U fibers, which are T2 dark, and then again, this thick band of tissue that is isointense to the cortex that represents the subcortical band heterotopia. So agyria and pachygyria are both characterized by an abnormal gyral pattern, and the gyri are thick and broad. There is also dyslamination, so it's not just an abnormally thick cortex, but also the layering is off, so it's they typically have 4 layers. On imaging, we can actually, in some cases, we are able to resolve 3 of these layers. So, and this is important on the axial T2 or any T2 weighted image for that matter. If you look closely, you can look at this T2 dark thin layer, which is the thin molecular layer. This is the T2 bright intermediate layer, which represents the cell sparse zone. So essentially, it represents the layer where neurons have not migrated to yet. And then this is a much thicker layer of that represents the arrested migrating neurons. The cell sparse zone is an important marker to identify what the gradient is, and we'll see examples of that. So age area, as we said, is most severe. It has this figure of 8 appearance. The Sylvian fissures are very rudimentary and have a vertical orientation. In this case, there is also ventriculomegaly. So this is the most severe form of, listen carefully, and the two most important genes that cause this phenotype are LIS1 and DCX. Rarely, some other genes such as TAB1A and CDK5 have been shown to cause this phenotype. Subcortical band heterotopia, again, this is a zoomed up image of what we saw before. So that's normal cortex, that is a layer of white matter, and then that is the abnormal band of heterotopia that is in the subcortical white matter. And you can see it's extending all the way here. It is more thick in this area, and then as we see, it's becoming thin as we go anteriorly. Again, in this group also, think of LIS1 and DCX, they are going to be the majority of cases. And essentially, we need to go back to the spectrum because a lot of these cases can have a combination of package area and subcortical band heterotopia. And in those cases, the gradient is important. So is the anterior aspect of the brain more involved or the posterior aspect? So looking at some cases now, this is a 3-year-old male with seizures. So what's the radiological impression here? There is, I think we can all agree, there is quite striking package area anteriorly, probably less so posteriorly. We do see some sulci here. And there are other abnormalities. The corpus callosum is not probably going to be absent because we see this parallel orientation of the lateral ventricles. So the radiological diagnosis here is going to be, again, this is listen carefully, but there is a gradient. So, and this is package area with an AP gradient. So with an AP gradient, the most common mutation is going to be in DCX, which encodes for double cortin protein, and this is involved in neuronal migration. This is a companion case. This is an 8-year-old female. Again, it's important. What is the abnormality here? So again, there is, some abnormality that you can see anteriorly. Posteriorly, it tends to kind of normalize, maybe probably not fully normal, but essentially what we are seeing here is another gradient, AP gradient. And in this case, if you look closely, there is cortex, there is white matter, and then there is this layer of cortex as well. So this is a subcortical band heterotopia, and this involves the anterior lobes more than the posterior lobes. And this is important because most females with DCX mutations tend to have this milder phenotype, whereas males with this mutation tend to have the more severe phenotype of package area and age area. And that's because it's an X-linked disease. Another companion case, 3-year-old female. Is there a gradient here? This is slightly difficult because these images were done. These are fast T2 weighted images. But I think even accounting for that, the T1 helps us quite a bit here. There is thickening of the cortex anteriorly. The gyri are a lot broader here compared to posteriorly. So there is definitely an AP gradient probably of the lysencephaly spectrum. And this patient had a mutation in ACTB gene causing Barrett-Winter syndrome. They can also have microcephaly and polymicrogyrias. Another companion case, 9-month-old male, this time with developmental delay and seizures. So do you see any gradient here? So take a few seconds. Again, yes, there is a gradient, but this is a reverse of what we saw before. There is some sulcation anteriorly, and then as we go posteriorly, the cortex becomes a lot smoother and thicker as well. The other important thing to note here is that if I zoom this, then we can see again the cell sparse layer there. And this can be seen better on the zoomed image. I don't know, the image quality may not be very good, but there is this T2 hyperintense linear signal between the molecular zone and the deep zone. That's the cell sparse zone. Why is it important? Is sometimes if we are not able to distinguish what the gradient is, identification of the cell sparse zone can help us. So the cell sparse zone is more prominent in, or better seen where the cortex is more involved. And this one with the PA gradient, LIS1 is the most common gene involved. This is a companion case, infant with global developmental delay and seizures. So again, what's the pattern here? These are T2 weighted images. We see posteriorly there is a pachygyric appearance, anteriorly not much so. So there is a PA gradient again. Corpus callosum, again in this case, there's parallel orientation of the lateral ventricle. So there's a degree of callosal hypogenesis or agenesis, and that we can confirm on the sagittal images. In addition to that, the white matter is abnormal. At this level, we see the basal ganglia look a bit dysplastic. The anterior horns of the lateral ventricle seem to be wrapped around the caudate nuclei there. Very typical appearance of the brainstem with asymmetry and this extensive midbrain hindbrain malformation. So PA gradient and all of these other findings very typical for tubulinopathy. And one of the causes for posterior pachygyria is, in addition to LIS1, is TUB-A1A, which this turned out to be. So genotype-phenotype correlation is quite strong for lysencephaly. So if we see an AP gradient, think of DCX is by far the most common, but the others are going to be your ACT-B, ACT-G1, which cause Barrett-Winter syndrome, and the Relian mutations, which also tend to have pontocerebellar hypoplasia phenotype. With a PA gradient, think of LIS1, which is the most common. Certain tubulinopathies like TUB-A1A, which we saw before, and TUB-G1 also have this gradient. And the rarer causes are going to be dynan C1H1, which is a microtubule-associated protein. This is a case from the literature, was described as a temporal predominant lysencephaly with callosal agenesis. And this is this turned out to be an ARX mutation. So if you see a case with temporal predominance and callosal agenesis, think of this. And finally, the most severe spectrum, that is agyria. The most common genes are LIS1 and DCX, and less commonly, they can be caused by TUB-A1A and CDK5. There are some peculiar forms of heterotopia. So this is case number 1. We can see this thick parasagittal band of heterotopic nodules. The ventricular system is enlarged. There is also overlying polymicrogyria here in the frontal and parietal lobes. So quite an extensive malformation. Infratentorially, the cerebellar hemispheres show extreme disfoliation. And this constellation of findings of cerebellar disfoliation, parasagittal band heterotopia with overlying polymicrogyria and ventriculomegaly is quite suggestive of Chudley-Makolo syndrome, which is due to GPSM2 mutations. This is courtesy of my friend and colleague, Dr. Sneha from Ghosh, and we saw an example of this before with microcephaly and this predominantly nodular subcortical heterotopia involving the perisylvian regions in this case, which was a CEP135 variant. Another case, courtesy of Dr. Sudhakar. In this one, there is this very extensive, almost a brain within brain kind of appearance. So this is described as ribbon-like heterotopia. The overlying cortex is also abnormal, and there is callosal agenesis, as we can see here. So this has been described in this very peculiar phenotype has been shown to be caused in AML1 variants. So if you see this phenotype, you could strongly suggest this particular diagnosis. Having said that, we still don't know a lot of things. And this case, for example, again, it looked similar to the AML1. There were slight differences because there was no callosal agenesis and there was this posterior predominance, but also this very ribbon kind of heterotopia. And we don't have a diagnosis for this yet. But the phenotype can be described as megalencephaly, polymicrogyria, and ribbon-like band heterotopia. And there's a very similar case in literature which was described, which was at that point, there was no genetic information on that. It was 2016, I think. But anyway, so the question is, could this be AML1 or could this be something else? We still don't know. And finally, we are moving on to malformations of cortical development due to over-migration. And that's going to be polymicrogyria and cobblestone malformations. So again, looking at the role of the glial limitants, it's very important here. Normally, it prevents over-migration of neurons. And in a normal case, there are no gaps here. And you see a normally formed cortex. If there are multiple small gaps, then these neurons tend to over-migrate and lie, lie along the leptomeninges. So if the gaps are small, they tend to cause polymicrogyria, as we can see here. If there are large gaps, then all of this forms like an irregular heap-like appearance, causing cobblestone malformation. As we can see here, frequently with cobblestone malformations, the white matter is also abnormal, which enables differentiation from polymicrogyria. So essentially, these both conditions are disorders of migration due to disruption of the glial limitants. Polymicrogyria, very heterogeneous, extreme phenotypic and genetic heterogeneity, as nicely defined in this paper. And the average diagnostic yield of whole genome sequencing was only 20% in this particular paper. But interestingly, if once they took the head circumference into consideration, so if there was polymicrogyria with macrocephaly, then the yield reached about 60%, mtauropathies being the majority of these. Microcephaly, not much, again 30%, and normocephaly, the yield is quite low at 12%. So I think what this tells us is in the context of macrocephaly plus PMG, we do tend to have a higher yield. Again, before thinking of genetic conditions, polymicrogyria, especially we need to think of congenital infections such as Torch and Zika, CMV being the most common. Of course, they tend to cause microcephaly with these malformations and the other important features of CMV, including white matter changes. Typically, presentation also will be with sensory neural hearing loss. The other important group is vascular disruptive events. So that is for example, an antenatal stroke that has taken place. So what that does is that disrupts the glia limitans, and then the polymicrogyria occurs secondary to that. And finally, certain metabolic disorders can cause polymicrogyria. So, for example, Zellweger syndrome is a good example of that. And it has a very wide imaging phenotype because these gaps differ in size and location. And the neuronal migration across these gaps is quite random. So case 8, neonate with seizures. And this is a good time to image the brain before myelination has started, because we see a very good contrast between the gray and white matter. So at this point, we can see this irregular stippled appearance involving the frontal and sylvian regions on both sides. So there is perisylvian polymicrogyria. You can also notice head circumference is quite big. The sagittal image, again on T1, the contrast is not great, but you can kind of make out this irregular appearance in the frontal and perisylvian regions compared to the posterior parts of the brain. So there is macrocephaly with frontal and perisylvian polymicrogyria. And this patient had a DEP-TC5 pathogenic variant. We saw that DEP-TC5 is part of the GATOR pathway, but closely linked to the mTOR pathway. So essentially, it's an mTORopathy. And the phenotype can be quite variable, including macrocephaly, focal cortical dysplasia with or without polymicrogyria. 2 companion cases, 8-month-old with microcephaly, seizures, and sensory neural hearing loss. And this is an axial T2 weighted image of the brain. So you can see bilateral extensive polymicrogyria, that is frontal, temporal, and insular predominant. In addition to that, there is some ventriculomegaly. There are confluent white matter changes. So the history was important here with sensory neural hearing loss and these changes. This turned out to be a congenital CMV. Whereas this other baby with dysmorphic features, again, if you see the axial T2 weighted image, is quite not very dissimilar to this, except that the white matter changes here are a lot more confluent. Again, we see frontal and perisylvian predominant polymicrogyria here. The again, differentiating feature clinically is very important. So constant discussion with the clinicians are extremely useful for us. And this baby had dysmorphic features, so underwent an AP knee X-ray, which showed this stippled appearance of the epiphysis, which allowed us to make a confident diagnosis of a peroxisomal disorder. And in this case, it was a Zellweger syndrome. It's the 19-month-old female, and we saw an example of this earlier in microcephaly. So there is microcephaly, and there is this polymicrogyria. So and this also had a frontal and perisylvian predominance. In this case, was WDR62 pathogenic variant. Moving on to cobblestone malformation. So it is described as irregular and pebbled-like cerebral surface. So if you imagine the glia limitans being disrupted, and then there's this heap of neurons that have migrated across it, and that causes this very pebblestone-like appearance. Typically, the white matter is also of abnormal signal intensity. The cortex is thick. It has this very jagged gray-white matter junction. And this is a zoomed up image of this area that shows these vertical striations. Again, an important feature to differentiate from polymicrogyria. This has a better genotype correlation compared to PMG, and the majority of cobblestone malformations occur due to alpha dystroglycanopathies, that is your Walker-Warburg syndrome, Fukuyama disease, etc. Again, important to rule out metabolic etiologies, because some of them can also cause cobblestone malformation. So case 9, infant with hypotonia, T2 weighted images, extensive bilateral cortical malformation in the form of cobblestone malformation. you can see here again the vertical striations that are quite typical. The white matter is diffusely abnormal. There is ventriculomegaly. There is this characteristic Z-shaped brainstem with cerebellar dysplasia and small cysts. Creatine kinase levels were elevated in this case. That's a radiological impression, but I think the entire phenotype and clinical picture is quite strongly in keeping with Walker-Warburg syndrome. So Walker-Warburg syndrome, as part of the alpha dystroglycanopathies, has brain, muscle, and eye abnormalities, and it occurs due to pathogenic variants in POMT1 and POMT2 genes. This is a companion case, and I show this because this is a bit difficult. I don't think we can confidently, at least I was not able to confidently say whether this is polymicrogyria or cobblestone. If I had to choose between the two, I would say maybe just on the appearance, it is cobblestone. But again, it's difficult, and these are the kind of cases where it's okay if you're not able to differentiate it. We can label it as PMG cobblestone spectrum or PMG cobblestone-like malformation. The important features here, however, are the distribution. So this is frontoparietal distribution that you can see in the cerebral cortices, in addition to cerebellar dysfoliation and microcysts. Creatine kinase in this case was normal, so these findings are quite typical for GPR56 mutations. They were known as GPR56 before the new name is ADG-RG1. And this is expressed in the neuronal progenitor cells of the ventricular and subventricular zones. So explaining that they can be involved in neurogenesis and migration. And finally, let's quickly look at, I think we're running out of time, but quickly we can look at dyscharya and FCD types 1 and 3, which are essentially MCDs that occur due to abnormal post-migrational organization. So dyscharya, as I said before, for lack of a better term, this term is used when there is abnormal gyral pattern characterized by irregularities of sulcal depth and or orientation. So you can see a very generalized pattern here, very chaotic appearing sulci and gyri, but the cortex is not thickened. Whereas in this case, you can see more focal abnormalities of this, funny looking, we are at the level of the vertex, so we should be seeing a nice superior frontal sulcus and central sulcus, but instead of that, we see these obliquely oriented sulci, even in this case. And these were cases of ACTA2 mutations. So essentially, dyscharya, can have a very variable appearance. We still are not completely clear on the imaging spectrum of it. We still use the term dyscharya because as of now, there's no better term. But the important things to keep in mind are the cortical thickness is normal and the gray white matter junction is smooth. There should not be any indistinction. If there is indistinction, then think of either PMG or some other malformation. And finally, to close the session, this is the coronal flare image. Where is the abnormality here? Take a few seconds. And hopefully we are able to appreciate that there is some asymmetry with the left temporal lobe compared to the right. On the right, we see good gray-white matter differentiation, but it's very blurry here. There is flare hyperintense signal of the white matter. In addition, there is probably some volume loss of the left temporal lobe compared to the right. And as you can see here, this is just one single image, but the malformation was quite extensive. It was not confined to like a transmantle sign, etc. So this is quite typical for type 1 cortical dysplasia, focal cortical dysplasia, and oftentimes structural MRI may not at least yield a very conspicuous abnormality, in which case FT Interictal PET images can help. So in this particular case, you could see this asymmetry, that is relative hypermetabolism in the left temporal, left anterior temporal lobe. And this turned out to be a type 1 FCD, and this occurs due to abnormal cortical lamination. There are differentials for this, which some of them are quite disputed in literature, but the differentials for this would be, the so-called MOGHI or myelin oligodendrocytosis with hyperplasia and oligodendrocytosis, etc. But an important, just from a practical standpoint, in cases with focal epilepsy, an important area to always look at before you close the study is these coronal planes of the temporal poles, because on the axial plane, they can be quite difficult to see this gray white matter differentiation, but on the coronal, once you align them to the same plane at the same level, always look for these asymmetries, and sometimes that's all the structural change that can be seen on imaging. This is a really nice diagnostic workflow from this paper in 2020. I'll not go into too much detail for that. Do refer to this paper. It's a very well-written paper with a lot of practical tips. Essentially, what it says is, if there is suspicion of a single gene disorder, you consider targeted testing, and that we saw examples of FLNA mutation, for example. If there is polymicrogyria or microcephaly, the first thing we need to do is exclude CMV and Zika, other torch infections. And if the phenotype is explained by these, then there is no need for additional testing. Microarray, gene panel, and open exome trios are done when it does not fit into any of these. And finally, the overall diagnosis sometimes is still not clear even after all these tests, and require multidisciplinary team discussions with the radiologist, geneticist, neurologist, etc. So the take-home points: malformations of cortical development occur due to defects in cell proliferation, migration, and organization. And many of these processes occur simultaneously, so they can have overlapping features. In addition to that, there are various epigenetic and environmental factors that need to be taken into account. And that's why no two brain malformations are exactly the same. The other important concept to remember, and we saw examples of this, is that the same gene can cause different phenotypes. So WTR62, for example, can cause microcephaly with polymicrogyria or just simplified gyral pattern. D6 mutation can cause subcortical band heterotopia or frank, severe age area. DEP-DC5 can cause polymicrogyria and FCD. And again, different genes cause a similar phenotype, and that's useful if you look at the whole thing as a pathway rather than single gene disorders. So, disorders of the mTOR pathway can cause overgrowth syndrome. Similarly, RAS-MAPK pathway can cause overgrowth syndromes. And finally, beware of mosaics. So when the mutation is somatic, it can be more straightforward to get the diagnosis, but sometimes there can be somatic mutations, and these are some of the genes where you can have somatic mutations. So in these cases, your genetic testing from blood can be normal, but you may need to have some other form of test, such as, for example, a brain biopsy that can help in differentiating or picking up these somatic mutations. With that, I conclude the talk, and happy to take any questions.
Thank you, Astik, for this excellent lecture. And there are several hundreds of clinical entities which have been described under the developmental and genetic classification of for the malformation of cortical development. And you have taken us through a systematic discussion, making this complex topic in a simplified way. So we can take up a few questions. I hope you have some time, or you want to leave. You're muted. Can you please unmute yourself?
I have some time, about 10 minutes, if that's okay.
Sure. So what specific sequences should the clinician request in children with suspected malformation of cortical development, presenting with developmental delay and refractory epilepsy?
So, I mean, it should include a routine MRI study, which should be done in most centers. So at the very least, T2 weighted sequences in the axial plane with or without another plane, such as a coronal plane. 3D T1 weighted images, flare images, and that depends on the age. So if they are less than 3 years of age, flare may not be very useful because of the poor contrast, but more than 3 years of age, a flare is a must, and the flare can be either a 2D flare or a 3D flare or both. And then the other ancillary sequences, sorry, not necessarily ancillary, but diffusion is a must. The other ancillary sequences would be SWI, and depending on if it's a metabolic disorder that you're suspecting, maybe even add in NMR spectroscopy. But the bulk of the workhorse is going to be your T1, T2, and flare images. And again, if it is focal epilepsy, then we would recommend a focal NFCD protocol, which we do here. So those are, we only run them on the 3 Tesla MRI, and they're quite high resolution images, and we do 3D flares on them. For the others, if the suspicion is not very high, then just a screening routine MRI should suffice.
Sure. Is there any utility of CT brain for pattern recognition in children with suspected genetic malformation of cortical development?
CT, I think the most useful roles CT can play is to look for calcifications. So, for example, but I think with the advent of MRI, the role is now quite limited. Some of the examples that I can think of is if you're looking for a dominant tuber in tuberous sclerosis, calcification can be seen on CT, but we do have SWI images now and MRI for that. The other thing in the context of epilepsy, could be Sturge-Weber syndrome. So again, calcification in that can be seen. Metabolic disorders, again, in the context of microcephaly, progressive microcephaly, CT can help to show calcification in things like Cockayne syndrome, etc. So I think it can be used in certain conditions as a problem-solving tool, but not necessarily should not be done in all cases.
Sure. And also in torch infections as well, I think.
Torch infections also, yes.
Dr. Ranjit has asked, you were discussing about a patient with PI3K mutation. So he was asking whether the mutation was derived from DNA in the blood, or it was derived from the brain or skin, because you said it was an heterozygous mosaic, and the chance of isolation from the affected tissue would be much better. So
yeah. So I don't know exactly where, but it was not from the blood. So I don't think they got brain either. It was probably from the skin, but yeah, I'm not 100% sure where it was. But the genetic report was that of a mosaic.
Sure. So there are a few other questions. How will you differentiate a simplified chiral pattern in an infant, in an early infancy, like when the tertiary sulcations are not complete? So how will you identify a simplified chiral pattern?
So tertiary sulci by themselves are very variable. So even in adults, they don't help us much. So we mostly look at the primary and secondary sulci, which are expected to be formed at birth. Having said that, it can be a challenge. It can be quite subjective. We have overcalled simplified chiral pattern. We have undercalled simplified chiral pattern. It is a subjective eyeballing as such that we do. Ideally speaking, we should have something like an AI that is able to compare the sulcation age match to and gender match to controls, and that should be able to help us more. Then in the same format, even dyschardia, like I said, it's very variable. We do struggle with it. Sometimes we overcall it, sometimes we undercall it. We are not even sure sometimes, if we can call it dyschardia or not. And that's because, again, it's the limitation of what we can see. What we are seeing is a 2D representation of a 3D structure. So there are limitations to that. So definitely not 100%, and there can be mistakes in interpretation.
Sure. So in children with with proven DEPTC5 mutation, so if they have a persistent focal motor seizures which are refractory to treatment, and the initial MRI is normal, 3T MRI is normal, so would you recommend like a follow-up imaging or a PET scan for further evaluation to look for any any underlying focal cortical malformation?
Yeah, so if the first MRI scan, for instance, was a 1.5T that was not tailored for focal cortical dysplasia, definitely would repeat it. The other instance would be if the first scan was done when the patient was, say, less than 3 years of age, when myelination may not have been complete yet, and there are ongoing refractory seizures, beyond that age. I would definitely repeat it. The other option, of course, what we tend to do here is, we have an MDT discussion. And I think if the second MRI is also negative, but there are refractory seizures, then with the help of the EEG findings, we decide whether or not to go for something like a PET study. And yeah, usually we take it from there. But if the first MRI is not of a diagnostic quality, or if it was done, say, less than 3 years of age, or if it was not in a 3 Tesla MRI, we would definitely repeat it.
Sure. Are there any differentiating features between GPR56 and alpha dystroglycanopathy spectrum neuroradiologically?
So GPR56 or ADGRG1, as it is now known, has a frontal and parietal predominance. There can be some white matter changes, but they are not as confluent as the cobblestone malformations of dystroglycanopathies. Similarly, the dystroglycanopathies tend to have a more generalized cobblestone malformation rather than being confined to the frontal and parietal lobes. The second thing is that ADGRG1 mutations, typically you don't see brainstem abnormalities, whereas alpha dystroglycanopathies, you can see brainstem abnormalities. We saw an example of that with a Z-shaped brainstem. The cerebellar changes in both can be quite similar with dysplasia and microcysts, so that doesn't help much. So it's mainly the distribution of the polymicrogyria / cobblestone, the white matter changes, and the brainstem.
How will you differentiate periventricular heterotropias from SEN of tuberous sclerosis radiologically?
That is a very good question. I actually had a slide for that, but then for lack of time, I did not show it. So in periventricular nodular heterotopia, the signal should be similar to gray matter on all sequences. So T2, T1, diffusion, on everything, it should be reproducible and similar to the isointense to cortex. Tuberous sclerosis, on the other hand, they are subependymal nodules, and they can be, depending on the age at which you scan them, they can be variable signal intensity, but typically they are T2 dark, and over time they calcify. Periventricular nodular heterotopia should not calcify. So SWI imaging is quite useful in addition to the T2 weighted image to differentiate these two.
Sure. So Dr. Nihal has given a comment saying that he would leave the protocoling to the neuroradiologist, especially when he sees a scan on the table with a clinical indication. So that would be the most appropriate way rather than clinicians deciding on it. So
Yeah,
request.
I completely and wholeheartedly agree with Nihal. Although there can be, I think, um, if there are no trained pediatric radiologists, and as a pediatric neurologist, if you have that insight, it would definitely help. But yes, otherwise, yeah, it is, better to be left to the radiologist.
Any experience of association of trisomy X chromosomes with malformations of cortical development?
Trisomy. So certain a lot of chromosomal disorders are known to cause malformations, and it's an ever-growing list. The most common that I can think of are 20q11 and 6p deletions. Trisomies itself, trisomy 21 can cause like a simplified gyral pattern or hypoplasia rather of the frontal lobes. So I think theoretically definitely possible, but I'm not sure as to what the incidence is.
Sure. And then there are a lot of applauds for your talk in the chat box and the Q&A boxes. Thank you so much, Hastik, for joining us. Ma'am, you want to
Thank you.
give your comments?
I will before I open to the other experts who will actually take it forward, although it was just that it was an excellent talk and thank you. We could not have rescheduled because this is the SIG going on the month, and next week is Ingrid who will be speaking. So, you can't ask for a change. So that is the only week left. So I'm really grateful to you that you joined, and there's a lot of appreciation for you, and we'll be looking forward to more association. And thank you so much, Astik. And Dr. Biju, I will now request you to make your comments.
Thanks, Astik. That was fantastic. It was an excellent overview, and I've heard you before as well. The just a practical question, for the practicing jobbing pediatric neurologist, like for example, you see microcephaly, and then the two main issues that we always face with this cortical development, as Sangeeta has already mentioned, is developmental delay and epilepsy. So when you see these children with microcephaly, particularly the WR62, we've seen quite a number of children with this mutation, but no two are the same. Sometimes the intellectual disability isn't that high at all. Are there any clues that from imaging that you can tell us how these children are going to behave, or do we need repeated imaging that we know that cortical malformations will develop over time?
Yeah, I think with respect to, like, for example, the WDR62 example that you gave, I don't think we see many cases to actually, to have a natural history kind of study based on imaging. But what we see generally in imaging kind of resonates with what you see clinically, in that there is, as you said, there is a very wide heterogeneity. There's a wide phenotype, and we saw that in that one example where one side there was only simplified gyral pattern, where the other side there was polymicrogyria. So they can, for example, not have polymicrogyria, just a simplified gyral pattern. Maybe in those cases they have only dev delay and no seizures. If there are coexisting malformations, that is, in the form of polymicrogyria, that may be more of an epileptogenic substrate. So I am theorizing here, but these are some of the things that might help.
And also sometimes there could be impact of other genetic modifiers as well. I think TBCD might modify WR. This
Yes,
is
exactly.
true, I
Yes.
think. Yeah.
Yeah.
The it's interesting, like one of the reasons why the imaging phenotype and genotype correlation is for targeted testing, and we always talk about targeted testing, but even when it is fairly clear that could be either a list one or a DCX, how many of us would go for a targeted testing? Would we, I mean, practically, like people I know, like would still go for a whole exome sequencing. Do you think there is a real role for a specific targeted? I mean, I suppose like maybe tuberous sclerosis. Like apart from those sort of conditions, like even for LIS1 and DCX, is there a role for targeted testing, or should we go for whole exome?
Best person to ask that is a geneticist. I think the change in at least partially explained by better access to genetic testing, and over the years, it has become cheaper to get whole exome or whole genome compared to targeted gene. So I think all of that plays a factor, and also like you said, there are so many genetic modifiers that could be there. So the whole picture might be more useful in some cases. But the practical question of it, I'm not sure. We usually over here we let the geneticists take the call following discussion with them.
And one last thing, it just crossed my mind, if I may. I know even at Ghosh, we sometimes request for DTI studies just to see, like, even if it is like to look at the arcuate fasciculus, for speech, etc., etc. But we often then don't get much discussion on it, although colleagues oblige in doing the DTI. Is there a role in or is it like just mad neurologists requesting all sorts of funny things, or is there a role for tractographies in these cases, in cortical malformations?
I think one of the major roles, at least for now, is still academic, not necessarily translated into clinical practice. There are certain axon pathfinding disorders, for example, which can benefit with DTI, such as your Joubert spectrum and things like that. So that can be quite useful. It can also be useful in pre and post surgery, so post hemispherotomy, for instance. If it can be useful to look for any remnant residual white matter tracts. Other than that, definitely has an academic purpose. We do need to do a lot of post-processing. We need to get the values and look at that. So it's not just a qualitative assessment. There's a lot, ideally speaking, there should be a lot of quantitative assessment to look at the fractional anisotropy, etc. So yes, I mean, in a busy clinical practice, we just tend to have the sequence and we keep it in the folder, but we don't really look at it unless it's like a Joubert or something like that.
Thank you. Fantastic talk, as always. Thank you.
Thank you, Dr. Biju. And yes, Astik, it was fantastic. But one thing, you were saying, and Nihal also said, Nihal, I'll ask Asmita to send you a panel, you to upgrade to you the panel so that you can talk directly. But I wanted to say that one should give a message that there should be the clinician and the radiologist should be having discussions, and that is very important to have a correct diagnosis. I think we've been having for donkey years, every week we have a neurораdio conference, which has been with Atin for long. And I mean, I think that is very important because then, you can discuss and have a good clinical phenotype with your imaging findings and all. And regarding the, like what you were asking about structured, I mean, so the focused genetic testing or not for any malformations per se, but like some conditions like SMA. I mean, it's not for malformation, not related, but, in that we are doing, if you are having that MLPA not showing, then we do SMN targeted sequencing because it will not be picked up very well in whole exome. So then in certain situations, we'll have to keep checking that, whether your pickup is okay or not. Otherwise, only in few cases, you would need specific targeted with this malformations. Yes, we have not looked into it. We have always been doing exome. We can just look into it. There is something is more for that. That was a very good question. Dr. Gopinathan. Dr. Gopinathan, your comments?
Yes. I think it's a very, I think the gene testing is...
Sir, can we see you?
Okay.
Yeah.
My thing is whether all cortical malformation has to go for gene testing or not. I think we are in the transition period. Now only we are telling which cases we have to go for gene testing. But if you do all the cases, if you do gene testing, every patient will have some kind of different kind of genotype and phenotype. Within, I think it's over a period of a few years, we can tell what kind of malformation associated with the gene problem. I think it's within a matter of years. Within 5 years, we can able to tell all the brain malformation association with the genetic correlation. I think
Absolutely, sir. We've had these talks, before these SIGs. We had one of the talks on personalized genomics, that everybody, and it was predicted by one of our very good friend, physician scientist who's working in genetics, that it will be 10 years, then we'll all be having our personal genomics data in practice. So now, Sam, back to you. Yeah.
Yes.
Yeah, completely agree. So-called genetic passport, we might all have in a few years of time. Dr. Gopinathan, to answer your question, I completely agree. I don't think, all cortical malformations need to be genetically tested. So, we need to think of acquired and clastic injuries as well.
I think both are mixing. The acquired and the classic are imaging is many times are mixing.
Many times they are mixing, exactly. Yeah, because the genetic.
The clinicians are asking whether to go for genetic test, and also the patient come for the next. I think when we are sitting our genetic counseling, they ask for next child can be same or whether it is transform or not. So at that time, very difficult to tell the answer.
Yeah, I completely agree.
Just keep in mind that you still have the CMV and all associated with malformations. That also has to be just kept in mind. So, yeah.
Asking how much is false positives and false negatives a problem here in cortical malformations or in?
So from an imaging point of view, some of the more recent ones that are not very clearly defined, for example, dysgeuria, we do tend to have quite a difference of opinion amongst us. And also not only inter-observer variability, I've also noticed intra-observer variability. Like one day if I might think there's dysgeuria, the other day I might think it's not. So I think for these things, there is a lot of variability. So it has to be taken into context of the clinical picture. MDT discussions with clinicians are extremely important. The other thing is, of course, subtle cortical dysplasias can be missed, can be overcalled. And that's the reason we have so many of these epilepsy meetings, to make sure that more than one person sees it. And we tend to get, whenever we have a discrepancy, we try to get a consensus view. Despite consensus views for many of the subtle FCD type 1s, etc., it can still be very difficult. And that just goes on to show that imaging has its limitations. So we have to be aware of that.
Thank you.
Dr. Bijoy, you have a vast experience too.
Thank you very much for adding me. Great talk, Astik. I learned a lot. One comment about the last case you showed, the temporal neocortical changes, we tend to overcall it as a focal cortical dysplasia type 1. Many times with the mesial temporal sclerosis, we see neocortical subtle poor gray-white differentiation. And we tend to call it as either a type 3 malformation along with hippocampal sclerosis, or a hippocampal sclerosis with neocortical changes. We have recently conducted a study on this with the histopathologically proven cases. The pathologists call a hippocampal sclerosis only when there is both neuronal loss as well as sclerosis, gliosis. What we really see in MR is just a gliotic part. That means when it is flare hyperintense or poor gray-white differentiation, we are not sure whether the Nguyen stain is going to show a neuronal loss. So calling a neocortical change as an FCD sometimes can be very, very difficult, especially when it is associated with hippocampal sclerosis.
Yes, completely agree with your point. So those cases, what I tend to call is, I tend to describe them as, ill definition of the gray white matter structures, usually with or without some volume loss. And these changes can either be due to a cortical dysplasia, or, in Toronto, we used to use the term oligodendrocytosis. In Europe, they tend to use MOGHE. At Gosh, they actually don't like both terms. And it is controversial to use the term seizure-associated changes here, because some of the experts here don't agree with that. So it can be a semantics thing, but yeah, I think theoretically we should keep in mind that they can either be dysplasias, they can be components of glioneuronal tumors, for instance, in a type 3C, or long-standing seizures can also cause some of these effects.
We found that there is some correlates with the clinical findings with the ASL hypoperfusion, and the brain MRI as such, the structural MRI as such, there is very, very poor correlation with histopathology, whether it's a neocortical secondary change or a primary dysplasia.
Okay, no, that's very interesting. We are trying to incorporate ASL in our clinical practice. We are still not very good at it, but hopefully, we should be able to do these more in the future. Please, if you could share your paper with us.
Sure. We are in the process of writing it, that paper. It's a pilot study, and we found that there is structurally there can be very variability, because pathologists will not do myelin stain routinely. What we are seeing just a myelin abnormality, not that neuronal abnormality, and we cannot actually differentiate basically from MR imaging alone. They do.
Myelin loss could also be secondary to.
But I found that when there is actually thickening of the amygdala, probably it is leading on to some sort of a malformation first, rather than just a poor gray weight differentiation and volume loss.
Yes.
Great talk.
Thank you so much. We are running 28 minutes late, but it was too interesting and engaging, and half of people, less than half, are still there. Sangeeta, you want to say something before we have one rapid fire messages from the speaker followed by the expert? Yeah, Sangeeta.
No, ma'am, there are no comments.
And you should say something. You have to sum up something.
Already, Astik has given a clear picture of radiological findings and the genetic correlates. So as a clinician, I think like phenotyping, clinical phenotype, history taking, and identification of dysmorphic features, microcephaly, macrocephaly is still more important. Followed by, then we need to proceed with the imaging with the help of the neuroradiologist. We can identify if there is any possible underlying single gene which can explain the underlying phenotype. In that case, probably we can go ahead with the targeted testing. Dr. Biju was asking, like, what would be the diagnostic yield when you have out of a targeted genetic panel? So the published literature says like the yield is only 15 to 35% when you go for the targeted genetic panels. But if you have a clear radiological phenotyping, then the yield becomes much more high. So the ideal method would be like to go ahead with the whole exome sequencing along with the inclusion of identification of copy number variants might increase the diagnostic yield in these children. So, yeah.
That's why, Sangeeta, whole genome is going to replace the whole exome, because your CNVs will come in the whole genome, which don't come in the whole exome, right?
Exactly. Yes, that's a very good point. Yeah.
Mona, you want to say something? Your hand is raised before we go. Final message from Astik. You want to say something, or is accidentally raised? Mona? Okay. Astik, take home message. Rapid fire. You have your striking doctors there, so.
No, I think if there is one take-home point, it is that liaising closely with the clinicians. This.
That was my point. Yeah, you have it's plagiarism. Yeah.
No, it's positive plagiarism. No, I think, yeah, I think, these cases are complex. A lot of times, the imaging finding may not be specific, but they can be, one clinical clue that can help us, like that case of Zellweger syndrome, where there was, very dysmorphic features, and then we asked for an X-ray, and that gave us the diagnosis. So it is very important, I think, to have a constant dialogue, and going forwards, if we might all end up having a genomic passport, but that may cause a lot more worry than than anything else, I suppose.
Double-edged sword, maybe, right?
Yeah.
Dr. Biju.
Completely agree with Astik. You could talk about potential disadvantages of etc., but I think as you showed in your final that neurology paper, and similar papers exist for like leukodystrophies as well. Like neuroimaging, I honestly believe that remains the crucial diagnostic tool for specifically for cortical malformations, and it is the first step in the diagnostic process. Absolutely no doubt. And the multidisciplinary approach, the combined clinical evaluation, genetic testing, and then advanced neuroimaging, if necessary, would then result in the accurate diagnosis. But in terms of the first step in the diagnostic process, I think absolutely neuroimaging is key.
Absolutely. You have so many neuroradiologists there. You have to say that.
I know. I think that
I'm joking.
What Nihal is doing, and ASIC, Kish, the spin team, it's fantastic. 10 years ago, like we wouldn't have had this opportunity to learn all this. And this is like, now it is like, even if you don't have to read, you just have to listen, and day after day, like this is it.
It's very, very, very important, and the listening is important.
Should give a huge shout out to Nihal and Astik, spin team, Kish, everybody. They have brought neuroradiology to the masses.
Yes, we have a spin and this collaboration.
Yeah, because I heard Bijoy gave a talk on ASL to Ghosh, and that was the first time I was hearing about ASL.
Dr. Gopinath.
You're muted, sir.
You mute.
Main thing, as you already told, the clinical correlation will be as a neuroradiologist. So we have to see the clinical thing. Then we have to tailor our imaging finding. That is as they already told. That is the main thing we have to keep in mind. That's all.
Dr. Bijoy.
I think these malformations are very complex. I think we have Nihal and Astik always to ask if there is a doubt. I think there is rather than asking clinicians, collaborating with the clinicians individually, I think we should have a neuroradiology network as well, because everybody has got difficult cases, and I think there should be platforms. Right now we communicate with the WhatsApp. I think there should be larger platforms with the considering patient confidentiality. We should discuss cases more often so that actually everybody will get benefited.
Dr. Bijoy, we are making a platform, which is nearly ready. There were some logistic issues with the genomics thing. Do you want that to be linked with that, or do you want that separate? Because that is there.
If it is linked, if we can actually, right now we are worried about patient confidentiality and ethics approval for uploading to any systems.
We'll have to mask it anyway. We'll have to mask the name. Some way it'll have to be blurred or something. We can blur it. We can blur in the images, right? Something.
Yeah, even then there are concerns, but I think we have to address that.
Yeah, okay, we'll just discuss, and I'll discuss offline with you guys, and that way we can do. Vaishak, being the secretary of this SIG, you have been totally silent. Vaishak?
Yeah, that's a fantastic talk. And
video on. Yeah.
I would like to thank the experts, Dr. Apin in his absence, Dr. Biju Hamid, Dr. Vijay Thomas, and thank you, Dr. Apin also.
Thank you, Vaishak. And I think Mahesh, it comes back to you for your comments. Your comments before your closing remarks and inviting for next week.
It was a really nice talk. I'm like addressing the importance of radiogenomics in the current era. I think we need to be more aware of all the different genes and get familiarized with all these genes so that we can appropriately counsel the parents. Nice talk.
Absolutely. So we can sign off also, Mahesh.
Okay, yeah. So I thank our speaker, Dr. Astik Viswas, for his wonderful talk. I would like to thank all the experts who joined us today and our moderator, Dr. Sangeeta. I thank all the delegates for attending.
One Mahesh, Astik, we didn't ask you. We are recording it. Can we put it on the website?
Yes, ma'am. Yeah.
No, we didn't ask. No, I'm asking Dr. Astik. It's okay.
Yeah, that's fine. No problem.
Yeah.
No, we're putting on the AOCN website. No problem. I'm sorry. I forgot to ask you. Yeah. Thanks. Thank you. Please, Mahesh.
Next Wednesday, we'll be having another interesting webinar by Dr. Ingrid Tain. The topic is novel treatable neurometabolic disorders. So I expect all the delegates to attend in big numbers and make use of that talk. I thank all the delegates and good night.
Thank you. Thanks. Thank you so much.
Thank you. Bye.
Bye, Sangeeta. Bye.
Thank you.
Bye.
Thank you.
Thank you, Sangeeta.
Asika.
Bye.
Thank you, ma'am.
Bye,
Thank you.
Sangeeta. Thank you.
Thank you.
Bye. Bye.